Paraganglioma and Pheochromocytoma, biochemical diagnosis and imaging localization. When your blood pressure spikes unexpectedly or your heart races without cause, the answer might be hidden deep inside your body, a tumor producing powerful hormones. In this evidence-based video curated by Saboor, fellowship-trained consultant surgeon, we will find out how to diagnose these dangerous tumors accurately. Pheochromocytoma, a tumor arising from chromaffin cells, specialized cells in the adrenal medulla that produces catecholamines, and paraganglioma, a tumor derived from extra-adrenal chromaffin cells, represent rare but potentially life-threatening conditions. A pheochromocytoma develops from the adrenal gland's inner layer, commonly producing one or more catecholamines, the stress hormones epinephrine, norepinephrine, and dopamine. Paragangliomas arise from sympathetic ganglia in the chest, abdomen, and pelvis, or from parasympathetic ganglia along nerves in the neck and skull base. Since the hormone effect and their origin cells are the same, these are called PPGL. These tumors matter profoundly to you because they cause excess cardiovascular morbidity and can be fatal if undiagnosed. The prevalence in patients with hypertension in general outpatient clinics varies between 2 in 1,000 to 6 in 1,000 patients. Diagnosis is often missed during life. Autopsy studies demonstrate undiagnosed tumors in approximately 1 in 2,000 patients. Before we dive deeper, let's establish what we're dealing with. The two-step diagnostic process that saves lives, biochemical confirmation followed by precise imaging localization. The cornerstone of diagnosis is measuring plasma-free metanephrines or urinary fractionated metanephrines. Plasma metanephrines, breakdown products of catecholamines produced continuously within tumor cells, are markers of pheochromocytoma, produced by catechol-O methyltransferase within tumors. This test offers superior diagnostic accuracy compared to measuring catecholamines directly, because metanephrines are produced continuously within chromaffin cells, regardless of whether the tumor is actively secreting hormones into the bloodstream. Here is what makes this test powerful. Free metanephrines are produced within adrenal chromaffin cells, or the tumors derived from these cells by membrane-bound catechol-O methyltransferase. According to multiple studies, measurements of plasma-free or urinary fractionated metanephrines are superior to other tests of catecholamine excess for diagnosis of PPGLs. The sensitivity can exceed 90% when performed correctly. But here is where it gets interesting. Certain medications and conditions can cause false positive results. Sympathomimetics, cocaine, tricyclic antidepressants, and some calcium channel blockers can interfere with test accuracy. Even intracerebral hemorrhage can cause catecholamine and metanephrine excess, creating a pseudo-pheochromocytoma picture. That is why your doctor needs to know every medication you take before testing. When plasma-free metanephrines show borderline elevations, a clonidine suppression test can help distinguish true positive from false positive results. This follow-up testing improves diagnostic accuracy significantly. Some laboratories now use liquid chromatography tandem mass spectrometry, a highly specific method that reduces false positives compared to enzyme immunoassay techniques. The pattern of elevation tells the story. Elevated norepinephrine suggests norepinephrine-producing tumors, typically extraadrenal paragangliomas. Elevated metanephrine points toward epinephrine-producing tumors, almost always located in the adrenal glands, because extraadrenal tissue typically lacks the enzyme that converts norepinephrine to epinephrine. Some tumors, particularly those with succinate dehydrogenase subunit B gene mutations, are biochemically silent, meaning they produce little or no catecholamines. Research shows that plasma methoxytyramine, a novel biomarker, can indicate metastatic disease, particularly in relation to tumor size, location, and SDHB mutation status. This marker becomes especially important if your doctor suspects aggressive disease. Chromogranin A measurements can serve as a complementary test when plasma fractionated metanephrines show borderline results, improving overall diagnostic accuracy. Once biochemical testing confirms excess catecholamine production, locating the tumor becomes critical. CT, computed tomography using X-rays to create detailed cross-sectional images, should be your first imaging option because most PPGLs are located in the abdomen. Modern CT scans can detect tumors 5 mm or larger. Because approximately 80 to 85% of tumors arise from the adrenal glands, a CT scan of abdomen and pelvis should be the initial choice. The use of non-ionic contrast is safe, and contrast CT can be performed without adrenergic receptor blockade. However, for certain patients, MRI, magnetic resonance imaging using magnetic fields and radio waves rather than radiation, becomes the preferred choice. MRI is recommended for patients with metastatic PPGLs, for detection of skull base and neck paragangliomas, where sensitivity reaches 90 to 95%, in patients with surgical clips causing CT artifacts, those with CT contrast allergy, and individuals in whom radiation exposure should be limited, including children, pregnant women, and patients with known germline mutations. Here's something that might surprise you. Pheochromocytomas typically show less than 60% washout of contrast on 15-minute delayed CT scanning, helping distinguish them from benign adrenal adenomas, which usually show greater than 60% washout. A high signal intensity on T2-weighted MRI images can be valuable for detecting PPGLs, though this finding is relatively uncommon in pheochromocytomas. CT is preferred to MRI for detection of lung metastatic lesions. Gallium PET, formerly called 68-Gododa somatostatin receptor PET cord, is now the first-line functional imaging test for PPGL. These tumors often express somatostatin receptors, and gallium tracers bind to this target with high sensitivity. The scan detects primary and metastatic disease better than older methods, and it provides rapid whole-body imaging in about 1 hour. Gallium PET also guides treatment by identifying patients who may benefit from PRRT. MIBG scanning is now used mainly when MIBG-based therapy is being considered. 18-FFDOPA PET is a highly sensitive functional scan for PPGL and is better than MIBG, CT, and MRI for locating catecholamine-producing tumors. It is particularly useful for localized adrenal pheochromocytomas and many head and neck paragangliomas. In modern practice, 68-Gododa PET is preferred first-line for SDHX-related and metastatic disease, while FDOPA PET remains an important complementary option when gallium is negative or unavailable. 18-FFDG PET measures tumor glucose metabolism and is the best scan for identifying aggressive PPGL, particularly in SDHB-related disease. It helps assess metastatic spread, tumor behavior, and prognosis by highlighting highly active cancer cells. FDG PET is often used alongside gallium PET, which maps somatostatin receptors and guides PRRT therapy, while FDG defines how biologically aggressive the disease is. MIBG imaging now has a limited role in PPGL. Many tumors, especially SDHB-related and head-neck paragangliomas, do not express enough norepinephrine transporter, so MIBG can be negative, with sensitivity often below 50%. Today, MIBG is used mainly to select patients for 131 IMIBG therapy, while gallium PET is preferred for routine diagnosis and staging. 18F-fluorodopamine PET targets the norepinephrine transporter and can provide very high sensitivity for many pheochromocytomas and sympathetic paragangliomas, with good whole-body detection of primary and metastatic lesions. Its main limitations are restricted availability, reduced performance in SDHB-related or dedifferentiated tumors, and the lack of a direct theranostic pathway, unlike gallium PET or MIBG. For these reasons, fluorodopamine PET is now used mainly as a specialist complementary test when first-line tracers are negative or unavailable. If you are worried about someone you love who carries a genetic mutation, understanding the tailored imaging approach matters enormously. Patients with SDHX mutations involving succinate dehydrogenase genes require specialized imaging protocols because their tumors behave differently. For SDHB mutation carriers, 18-FFDG PET is often superior because these tumors tend to be more aggressive and may not concentrate MIBG effectively. The modern algorithm is centered on 68-Gododa PET. For adrenal pheochromocytoma, FDOPA PET or gallium PET are appropriate, with FDG added for suspected aggressive disease. For skull base and neck paragangliomas, gallium PET is the preferred first-line test, with FDOPA as an alternative. In metastatic PPGL, gallium PET maps disease and guides PRRT, while FDG PET assesses tumor aggressiveness. MIBG is now used mainly to select patients for MIBG-based therapy. In SDHX mutation carriers, structured surveillance with anatomical and functional imaging enables early detection and reduces complications. If you have unexplained hypertension, particularly with episodic symptoms like headaches, sweating, or rapid heartbeat, discuss biochemical testing with your physician immediately. Before testing, compile a complete medication list, including over-the-counter supplements. Certain antidepressants, decongestants, and even acetaminophen can interfere with test accuracy. Stop interfering medications at least 2 weeks before testing if your doctor approves. That is approximately 14 days of medication-free testing preparation. For optimal plasma metanephrine testing, you should rest in a supine position, lying flat on your back, for at least 20 to 30 minutes before blood draw. This reduces false positive results from stress-induced catecholamine release. Avoid caffeine for at least 12 hours before testing. That means no coffee, tea, energy drinks, or chocolate. Even physiological stress like infection or recent surgery can elevate results, so timing matters. Prepare specific questions. Given my symptoms and blood pressure pattern, should I have plasma metanephrine testing? If my metanephrines are elevated, which imaging study should come first, CT or MRI? Do I need genetic testing for hereditary syndromes? If my tumor is confirmed, what is the risk of malignancy based on location and genetics? For patients with confirmed diagnosis, which functional imaging, 123 IMIBG, 18F-DOPA PET, or 18F-FDG PET is most appropriate for my specific tumor type. Should my family members undergo genetic testing? What is the recommended surveillance schedule after treatment? Understanding that lifelong annual biochemical testing is suggested to assess for recurrent or metastatic disease helps frame long-term expectations. If you are supporting someone through this diagnosis, ask about multidisciplinary team involvement. Personalized management with evaluation and treatment by teams with appropriate expertise, including endocrinologists, surgeons, radiologists, nuclear medicine specialists, and genetic counselors, improves outcomes significantly. Seek emergency care for hypertensive crisis, that is blood pressure exceeding 180/120ths, with symptoms like severe headache, chest pain, shortness of breath, or visual changes. This can indicate catecholamine surge from tumor manipulation or spontaneous hemorrhage into the tumor. Contact your doctor urgently if you develop new symptoms after diagnosis but before treatment. Worsening hypertension patterns, new cardiac arrhythmias, irregular heartbeats, or symptoms suggesting metastatic spread like bone pain or unexplained weight loss. These warning signs require immediate imaging reassessment and potential treatment modification. For patients with genetic mutations but no current tumor, adhere strictly to recommended surveillance intervals. Missing surveillance can allow tumors to grow large or metastasize before detection. Annual biochemical testing is essential, that is once every 12 months at minimum for high-risk mutation carriers. The diagnostic journey combines biochemical confirmation through plasma metanephrines with tailored imaging based on tumor location and genetics. Your next step: if symptoms suggest possible PPGL, request biochemical testing before anatomical imaging. This information is for education. Always discuss your individual situation with your healthcare provider. The Endocrine Society Clinical Practice Guidelines provide comprehensive evidence-based recommendations for PPGL diagnosis and management. Genetic testing through accredited laboratories is recommended for all patients, particularly those with paraganglioma, who should be tested for SDHX mutations, and those with metastatic disease for SDHB mutations.